Okay.
Right. Well, thanks very much, Jonathan, for inviting me. It's a real privilege to be here. And as you said, I'm a normal GP, as in I see all primary care once or twice a week. But my other role is a researcher, and I'm particularly interested in UTIs and how we might diagnose and manage them more effectively. So Katrina covered a lot of this, but she did then talk about a lot of other things. So hopefully you've forgotten some of it, and it's worth just running over some of these points again from a very much a kind of frontline GP perspective. UTI is a primary care diagnostic challenge. It is the commonest bacterial infection we see, and it's where the majority of antibiotics are prescribed, is in primary care. And what I think we're aiming to do as GPs is to only give antibiotics to patients with UTI, which avoids misdiagnosis of other important causes of symptoms, such as endometriosis, such as cancer, and avoid undertreating UTI for all the reasons that have been discussed already today. And then we want to select an antibiotic to use which is really likely to treat the infection while minimizing the side effects. And why is this important? Well, we know that community general practice prescribing closely correlates with the extent of antibiotic resistance for a number of different bacterial. We know that we're prescribing about 6 million antibiotics a year for UTI just in the UK. We know it doesn't just affect the individual, but the population to have this circulating level of resistance. Community prescribing, we've shown in data from Oxford, affects resistance of subsequent UTIs and bloodstream infections. The odds of having a resistant infection, if you've got one already, is pretty high, even up to 80% within a month of your first infection. And resistant infections cause longer durations of symptoms, even if they're sensitive to the antibiotic that was given. And it's important because these antibiotics do cause side effects. There's been a recent alert from the MHRA that we shouldn't be prescribing long courses of nitrofurantoin. And broader spectrum antibiotics carry additional risk, particularly in more vulnerable populations, such as older, frail adults. So how do GPs currently decide who needs antibiotics? Well, this is pretty much what happens at my surgery. I know Katrina had a few extra steps, which perhaps I should pay attention to in the future. But in terms of symptoms, in terms of what actually happens, rather, this is very variable. So we did a survey of a few hundred practitioners. We said, what do you do? And these boxes just really say that everyone did something different and there was no real consensus on what was the standard management. So what do we know from the evidence generated from primary care, from GP settings? Well, we know that cloudy urine could be something useful. So this idea that you hold something up to the light and have a look could be a valuable starting point. And that's on 2 different studies, both of which showed that the odds of infection were higher if the urine was cloudy. Am I in?
This is a big move.
Pause for stage left. Dipsticks, as already mentioned, are very sensitive. They're qualitative. That means that when you look at them, your perception of colour will affect how you interpret them. They have multiple variables, many of which are not particularly relevant to the UTI, and it's unclear how to interpret them altogether. The diagnostic performance is poor in primary care, as Katrina said, and there's a really beautiful trial done some time ago now by a Welsh group, which randomised women with negative urine dipsticks to have antibiotics or not, and showed that antibiotics resulted in faster resolution of symptoms, which for me was the nail in the coffin of believing the dipstick is the only thing in a holistic assessment of a patient. I wanted to talk a little bit about diagnostic algorithms because that is what we're meant to use as GPs to guide care. And there are usefully 2 different algorithms depending on where you live in the UK. So this is the UK HSA, and there is one about to be released, which is an update, I should say, but this is the current UK HSA guidance. And this is the SIGN guidance. And they're very different. I think some of you will have engaged with these and seen how different they are. But we thought that it might be interesting to look at how well they do perform in identifying women who have a positive urine culture, accepting all the potential limits of what a positive urine culture is currently. So we looked at this using a study population we'd recruited for something different of over 1,000 women with suspected and complicated UTI, and we followed through how they would have fared in the guidance and then what they actually had as a urine culture at the end of the process. Now, you don't really need to look at this, apart from the fact that I wanted to point out that in the current guidance, this red box doesn't exist. So there's a flowchart in the guidance which no one could get to, which is if you have a negative a dipstick that's negative for some things but positive for blood. So having added that in, we had a look at how well this performed. And in the women where UTI was deemed to be less likely, so you would be advised not to prescribe, we had more positive than negative cultures in that group. This is a different way of explaining that that's a bit easier to look at. So the dots being dark, fully dark dots for positive cultures, the double circles for mixed, and the open circles for no significant growth. And in the categorization by the algorithm, you can see that in all three groups, there were still more women with positive than negative cultures. So we also did the same thing looking at the Scottish guidance, which is a bit more harsh. You have to have a nitrate on your dipstick test really to have an immediate offer of antibiotics. And in this, let's go back one. And in this case, women who would be advised to have self-care or consider a urine culture had overwhelmingly more positive than negative samples. So under the sign guidance, hardly any women with a negative culture would have received antibiotics, but also only 13% of women with a positive culture would have received antibiotics, so it may be undertreating. Whereas in the UK HSA guidance, we probably approximately appropriately capturing those with positive cultures, but 61% of them with negative cultures would also be offered antibiotics, so it may be overtreating. And really our conclusion from all of this was that if you just use symptoms and dipsticks alone, it's probably not possible to accurately predict who would have a positive urine culture, let alone who would have a treatable UTI. We've talked quite a bit about urine cultures as being an imperfect reference standard diagnostics. And one thing Katrina didn't mention that is very relevant to my practice is that there's a really long delay to receiving the result. And it's often not until the antibiotic course is complete that we'll receive it as a GP, let alone be able to get hold of the patient, and none of us work full time. And so that requires handover of results and follow-up as well. 30% of the results we receive in Oxygen are contaminated, which means they're clinically useless for us. We've already discussed that they're based on antiquated criteria. They don't help us distinguish between infection and asymptomatic carriage of bacteria. They may miss potential infections, and we're not sure what transport time does to these samples, whether it causes an overgrowth or it causes death of infecting bacteria, or both in different situations on different days. So this is quite a lot of preamble for me really to say that I think there's a case for point of care testing to improve correct diagnosis and to improve correct antibiotic prescription in primary care and secondary care settings. But I'm going to focus here on point of care tests, being tests that are able to give a result rapidly for a single sample, as those are the ones that we think most likely to be useful in the community going forwards. So how might point of care tests help? Well, the ideal would be that the information is available rapidly enough to guide prescribing. So it's a point of prescription tests, and those are the ones that we're most interested in supporting. It could be that having really rapid tests might reduce this risk of contamination. Again, we don't know what the effective transport time is, but it might reduce contamination because of the immediacy of the testing. So one type of approach to point of care testing is bacterial identification. And the idea here is that you'd be able to make a positive diagnosis of UTI, you'd avoid unnecessary antibiotics and consider alternative diagnosis if the test was negative. And there is some thinking that by knowing exactly which bacteria you've got, it might help in targeting antibiotics. Another option could be to look at phenotypic diagnosis. So that's not necessarily knowing what type of bacteria is in the urine, but being able to know which antibiotics successfully kill those bacteria and that it's likely to be a bacteria that would cause a urine infection. That would help you to know that the antibiotic choice you're making is guided by actual sensitivities rather than effectively a prescribing policy, which is a regional database policy. And that's important because we don't submit cultures on everyone, as I'm sure you all know, and therefore the population where we do submit cultures is not reflective of all of the infections in the community. Also, very importantly for the primary care angle is to try and support usage of narrow spectrum antibiotics, perhaps older antibiotics, but ones like amoxicillin, which Katrina mentioned has 100% resistance in some contexts. If we could have those antibiotics back in our armory, they would help patients because they have less side effects, and they would help us preserve these more modern antibiotics with more side effects for the cases that really need them. So I was asked to talk about point of care tests that are available now and in the future. And to be honest, point of care tests that actually have the evidence base to be used in my surgery now, I'm not aware of any apart from the urine dipstick. But I think available soon, there's a bigger armory. And I just wanted to briefly mention urine collection devices, because that is a form of point of care test. It's an attempt to try and reduce the amount of contamination in samples by using a device to capture just the midstream of the flow. And we looked at these samples in a large study, which was called Conduct, to see if they would be worth using, because they cost a lot more than a standard part and a set of instructions. And we did a 3-arm trial with 2 different devices. These are the pictures of the 2. They were called the Whizzaway and the Peasy Midstream. And we compared them to a set of instructions on how to take a midstream sample, and found that there was no difference in the proportion of contaminated samples. So probably, at least for now, this may not be something that's helpful. How about tests that are available soon? Well, first, looking at this concept of bacterial identification, there are a number of tests that are coming up to being nearly usable, which try to identify the bacteria in your urine sample quickly enough for the prescriber to make a decision. Some of them use genetic codes, so molecular techniques. Some of them are using imaging to look at the shape of the bacteria and various probes to then, from that shape, work out what's going on. I'm going to mention a few different companies here because I think it's nice to show real-world examples that are coming into use, but these are not the only companies, and they're slightly determined by the ones that responded to my email and said, can I use your pictures? So maybe the more motivated ones to read my emails. So one example here is the Lodestar UTI kit, which is from Lucerne Scientific over in Wales, and this is a LAMP assay, which is a way of detecting the DNA of the bacteria. It takes about 30 minutes to give a result, and it detects 6 common uropathogens, which I would say cover the majority of what causes the UTIs that I see. Obviously, there are more specialist, there are more complicated UTIs out there, but this would be the majority of primary care. It's fairly simple to use. It does require a pipette, and the reason I know that is that we're currently evaluating this one in my GP surgery, and we've had to get a YouTube video on how to use a pipette so that the GP staff knew how to perform the test. So the other type of diagnostic that's available now is the one that looks at bacterial presence and the sensitivity to the antibiotics. So it's not telling you which bacteria they are, but it's saying there have been bacteria isolated, and usually can give a quantification of how much. Then has a process where those bacteria are exposed to antibiotics. And then a clever type of sensing technology of some kind, which can indicate whether they're sensitive to these antibiotics or not. So in about 45 minutes to an hour to 2 hours, depending on the technology, you would have an answer that says, yes, there's an infection, and this antibiotic could be used to treat it. So one example of this is the Sysmex Astrago machine. This is a machine that was developed by a Swedish team. We met them at that point, but it's since been bought by Sysmex, which is a multinational diagnostics provider. And it has this clever cartridge, this black square that you put the sample directly into and then put it in that white box. And it can estimate the bacterial load and then conducts an antibiotic susceptibility test to guide the treatment result. And the way it does it is it uses microfluidics, which for GP level scientists like me means the bacteria get to line up on little channels, and then you inject the antibiotic on the other end of the same little channels, and you look to see whether the bacteria continue to multiply because they're still alive and happy, or don't because they're either not happy in a way that stopped them multiplying or dead. And the Sysmex Astrago system looks at 5 different bacterial species and 5 different antibiotics. So a third option, which I haven't yet mentioned, which I think is coming towards something that could be really valuable, is looking at the host response. So there's a lot of complications about us trying to use bacterial presence to diagnose UTI in certain populations. And that's particularly relevant for patients who I would see commonly in care homes or other facilities who lack the ability to really communicate their symptoms anymore and are often therefore deemed to have UTI, or patients who don't experience typical symptoms, for example, perhaps because they don't have, they've got some neurological symptom, which means they can't feel in that area. So to try and overcome that challenge of when have we just got some carriage of bacteria in our bladder, and when is this genuine infection? One answer could be biomarkers. Now, I had a research assistant who spent his last year with our team doing a systematic review of all the studies that have ever looked at biomarker in the urine to determine UTI, and he enjoyed it so much that he left to join the prison service. But his paper is out there, so Edwards et al. And what he found was 66 different biomarkers have been looked at in 37 different studies, but no real convincing evidence for any of them to date. But obviously there could be the potential here for faster and cheaper diagnosis. It could be your new urine dipstick. The other thing I would say is that there's obviously host response really might be individual to women, so there's less known about what the variability is between women or over time in the same woman and over time in the cycle, the menstrual cycle of the same women, or related to other drugs for this type of, so I think more careful work maybe need to really understand that. Having said that, there is one test that is approaching the market. This is by Global Access Diagnostics, called UTIs, and it's a dipstick, and in a few minutes, I actually can't remember how many, I think about 10 to 15. Hope no one's here. We'll give you a positive or negative result based on a panel of biomarkers. So I'd anticipate the next question might be, so why are these tests not already in the GP surgeries? You just told me they're really good and they work. And one answer is that they have been evaluated. So the NICE health technology evaluation process ran last January, February time to look at point-of-care tests for UTI, and they found a number of candidate technologies, including the ones that I've shown you here, but found that the evidence for accuracy and effectiveness in context settings was not yet sufficient to recommend implementation. So that process is going to continue now, which is encouraging because we want this to be one of the forerunner processes for these kinds of diagnostics, and hopefully the evidence that my team and other teams are generating will help to provide that kind of basic level of requirement before that they can be recommended. And I think it is important that we generate that evidence first. So I think it's important that we take tests and we put them in the settings that we need them to work in for patient care and check that they work properly in that setting and that they're safe to work in that setting. And one really good recent example of this is this work by John Deeks' lab, where they took the Cochrane, so an independent research-generated estimate of accuracy of lateral flow tests for COVID, and they compared it to the tests that have been, accuracy that have been claimed by manufacturers based on their laboratory testing. And as you can see, overwhelmingly, the sensitivity was much lower in real-world settings in the Cochrane work than it was in the IFU, although the specificity was fairly similar. It's also important because I think this is gradually becoming a regulatory requirement. So the new European way in which we regulate diagnostics requires that near-patient testing or point-of-care testing is evaluated in the relevant environments, for example, the home or the emergency unit or the ambulance that it will be used in. And that has to be part of the evidence that a company will present before they can get their CEI VDR. So leading on to the study that we're doing to try and help this is called the Toucan study. And it's a prospective platform where we will take in novel UTI diagnostics into primary care settings and look at how well they perform. And the basic premise of this is that women can often produce a lot of urine, which means that for a single sample, we can evaluate more than one test. And that gives us the power to efficiently evaluate multiple tests over a shorter period of time than lots of individual research projects could do. And it allows us to tailor how we evaluate those tests to how well we think they're going to perform. So we can be aiming to look at the confidence that we place around our estimates of performance appropriate to what the test providers, the test manufacturers think is going to happen. It's also really flexible, so we have some tests in the Toucan program which provide a definitive diagnostic performance, and they're going to be close to market. So we want to know really how they work on a large scale, big sample size. And we're also allowing early stage developers to come in and get some valuable samples to help inform their development. So accepting this isn't the last version of your device and these samples might help you make a better test, but that's really important too, and it's quite hard to get those samples in the UK. The other thing that I like about this design is that we've discussed at length now the problems with urine culture. But yet urine culture is really our only, at the moment, our only true diagnostic marker. It's the only reference standard that we have. So by using multiple tests at the same time in GP surgeries, if all of them disagree with the reference standard urine culture, we might be able to say, well, these tests might be performing better. They might be detecting bacteria that the standard process cannot. So in this study, we're recruiting adult women. There's a brief consent process. They then allow us to take their sample and we perform up to 3 different tests on it, following the instructions the manufacturers have given us, and then we send them for an enhanced reference standard testing, culturing down to levels below the CAS criteria in a central laboratory. And we've got over 300 women already recruited, and we're running through till next December. So what about the future? And I think this is kind of the key bit. These tests are going to be starting to come into the market, I would say, next 5 years, hopefully before then. And I think it's important that more than one type of these different diagnostics is available, because it's not, the whole UK isn't going to buy one of these tests, but the competition is driving down the time it takes, increasing the range of antibiotics that we can see. And it might be that combinations of tests with a host biomarker and a phenotypic or bacterial identification element are going to be the way forward. It also might be possible that in the future we get to very rapid metagenomic sequencing. And again, there are many providers, but Nick here today is from the Systems Biology Laboratory, and we've been working with them a bit to look at how this metagenomic direct from sample sequencing could be used as part of patient care. And that's with an eye on, in 5 years' time and 10 years' time, could that be fast enough and automated enough that I could have one of these little boxes in my GP surgery? The other thing that I think needs to happen in the future, and isn't really happening yet, although I say it every time I meet a diagnostics company, is how about if your panel had other differential diagnoses that I might want to know, other causes for these symptoms that I might want to know as a GP, particularly including STIs, which in a certain population we aren't really equipped to test at the same time as the urine. And I think the other thing I'm seeing in development is tests that are more bespoke for certain use cases. So tests that are aiming to look at treatment response, tests that are aiming to find certain really important bits of antibiotic resistance that would affect secondary care decisions quickly. Tests that are trying to stratify causes for a current UTI, or that are useful in contexts where the majority of patients have dementia. Tests that are really thermostable and able to be bounced a lot, so that they can be used in ambulances, or they can be used in countries where the refrigeration, for example, isn't going to be reliable. And what I'd like to see also is a particular attention on pregnancy, where I think at the moment the pathways that we're using are not quite fit for purpose, perhaps. So I'll stop there, but I'm keen to have any questions, and keen to talk to anyone later who'd like to share any thoughts or collaborate.